the static zone will be 100% clinical and easy to digest. So sit back, relax, and hopefully enjoy the treatment outcomes. I will discuss with you uncommon solutions for missing teeth in the static zone due to agenesis, malformation, and traumas. Agenesis of upper lateral incisors, unilateral or bilateral, and missing upper canines. To open or to close, like in this patient where we close the spaces and in this patient where we open the spaces, it's not going to be today's topic. We have published 2 papers in 2 journals. One has been published in the AJODO in September 2016 with the topic aesthetic evaluation of implants versus canine substitutions in patients with congenitally missing lateral incisors. And the editor bestowed us with the cover of this issue. The second paper has been published in the JCO in 2018. These are some samples of our patients where we close the spaces, and these are some samples where we open the spaces for missing lateral incisors. Agenesis of upper lateral incisors, the prevalence is quite common, between 1.5 to 3% of the whole population. Which are the strategies of treatment for agenesis, patients with agenesis, lateral incisors? Space closure by canine substitution, mesialization, and the second strategy is to space opening for later prosthodontic replacement. Or is there a third option? I would like to present you Andrea. Andrea came to us at the age of 18 years. She has a nice profile. She has a little bit short profile. She has good lip competency. And this is her smile. You see immediately that she is missing a lateral upper incisor on the left side and the back-shaped lateral incisor on the right side, with some spacings. This is her intraoral situation. More or less a class 1 occlusion with some deep bite and missing upper lateral left incisor. The Sitges canine on the left side is still present. So this is the CEF, which confirms us a class 1 occlusion, and the panoramic X-ray, which confirms us that 22 and 25 are missing. What is our treatment plan on her? We are going to extract the Sitges canine 63. Why do we extract this 63? Because he has no roots anymore, no root anymore. And our treatment plan consists in mesializing of 24 and to provide her with an implant-borne crown on 24. So we call this a third option of substitution. Very quickly, our mechanics, very simple mechanics, as you can see here, very straightforward, with some accessories, tandem mechanics, we call it tandem mechanics for mesialization of 24 in order to avoid rotations and to facilitate the bodily movement of 24. Coming towards the end of our treatment, we check the occlusion. We have to remove some brackets. We have to do some composite restorations in order to handle the width of the teeth better. You see that we have removed the brackets. We did some composite reconstructions in the office. We did some gingival recontouring with the laser, and now we are going to rebond the brackets, rebracketing, with having better orientation for the finishing. Now we're coming towards the finishing. We're very close to the finishing, as you can see here. What are we going to do coming to this point? We are taking a panoramic X-ray in order to check root parallelism, in order to check ongoing root resorptions, and we take a smile picture in order to check smile aesthetics, to check the smile line, if the smile line is harmonious, smile arc if the smile is consonant, and after checking the smile aesthetics and after checking the panoramic X-ray, we are continuing to finish our case, and this is the day of the bonding. Some reconstruction, some composite reconstructions are going to be done, and some further gingivectomies. And this is the final occlusion. We bond two retainers, one upper and one lower retainer. We provide her with an Essex retainer, and then we send her to the general dentist, to her dentist. And this is the final situation after the prosthodontist has replaced the missing tooth. And this is the final occlusion, where we started at the end of our treatment, at the end of the restorative work. So where we started, where we arrived, arch from before we started, arch from after treatment, after visualization of 23 and 24, implant-borne crown on 24. And we keep the deciduous molar. Why do we keep it? Because he has a good root, and we are quite sure that the tooth will last for many years more, for more years. Yeah, therefore we keep it. This is the panoramic X-ray before and after, and showing this picture to the most experts, dentists, orthodontists, restorative dentists. I bet that it's very difficult to find out which tooth is which tooth. 21, 23, 24. I hope that you agree. And this is the smile before and after our treatment. Once again, smile before and after our treatment. And we can consider a nice final treatment result. The first issue of this year's seminars in orthodontics just came out in March, and the guest editor of this issue was my wife Ute. With the topic of this issue was cutting-edge interdisciplinary orthodontic prosthodontic treatment, and if you're interested, you will find one of these patients published in this issue of Seminars Orthodontics. Coming to the second patient, Dominic. Dominic came to us at the age of 11 years in 2006 with a retrognatic mandible. This is his smile. And this is his intraoral situation. It's a mixed dentition at full class 2. You have realized that he is missing upper lateral incisors. And this is the panoramic X-ray, which reveals severe crowding in the upper arch, which reveals missing lateral incisors bilaterally, which reveals a complete transposition of both canines, and which reveals a highly impacted upper lateral canine. The prevalence of transposition in the maxilla, according to Mike Papadopoulos, is 0.3% of the population, very often in combination with missing upper lateral incisors, according to Lena and Schellenbeck. So this is the riddle now, and I would like to ask you to help me to solve this riddle. in this situation. We have to do something. We have to think outside of the box. And who helped us many years ago? This is one of the most stunning case reports we found in the literature. Bill Zackerson's case report, where he is showing a boy, a 10-year-old boy, who has got an avulsion of several incisors in the upper arch, which have been replaced by transplanted, and he is showing transplanted by cuspids, and he is showing the patient 20 years later. So the first picture is at the age of 10, and the second picture is of the patient 30 years of age. Bill Zackerson is a master clinician. Bill Zackerson is an icon in orthodontics. Bill Zackerson is our mentor, who was stimulating us continuously to strive for excellence. And we owe him a lot. And you see in this publication of 2000 by Eva Szorowska, she is presenting materials of Bill Zackerson and Stenvik, what they have done in the 70s, auto-transplantating bicuspids in the area of missing upper lateral incisors. And she has been awarded with the prestigious Jewel Award in 2000 by the American Association. And having this in mind, our treatment plan consisted in moving the first bicuspid into the sides of the missing lateral incisors. And you see what we are doing. And you see after a while of treatment, the right bicuspid is erupting. We have created space for 23, and now we are going to expose 23, and we brought 23 into the arc, and now we are going to close the spaces with very simple treatment mechanics. And this is our final treatment result. The bicuspids are substituting the missing lateral incisors. And of course, we are going to end up with the molars in a class 2 relationship. And this is Dominik Smile after 28 months of treatment. The treatment lasted a little bit longer due to the infected canine. And this is Dominik 10 years later. We are lucky to show him 10 years later. This is Dominik 10 years later. And this is his occlusion 10 years later. Now he has 28 teeth because the third molars in the upper arch have erupted and are substituting the missing lateral incisors. He went to our colleague and good friend, prosthodontist Giuseppe Pelliteri, for improvement of the aesthetics, and he performed some ceramic veneers on the bicuspid in order to camouflage them as lateral incisors. Panoramic X-ray before we started, after our treatment, and 10 years later, showing that he has 28 own teeth. And if I show this picture to very expert dentists, orthodontists, or prosthodontists, I dare that they are finding out which tooth is which tooth if we are going to show him this situation. So, coming to agenesis of canines in this patient. Agenesis, the prevalence of agenesis is quite rare. It's 0.1 to 0.3 percentages in the population, so fortunately it's not happening so often. And I would like to share with you Sonia. Sonia came to us at the age of 15 years. She has a nice profile. She has spaces when she is smiling. Yeah, three-quarter smile with spacings. And this is her intraoral situation. a class 2 malocclusion with spacings, accentuated curve of speed in the lower arch, nice arch forms, the deciduous canines are still present, worn down incisors in the upper arch and the lower arch, and back-shaped lateral incisors in the upper arch. So this is her Ceph. She has a retrognatic position of the maxilla and the mandible, and she has good dental values. Looking at the panoramic X-rays, it confirms that she is missing the canines, and it confirms that she is missing two bicuspids, 15 and 45. The deciduous canines are still present, one without a root anymore, and the other one has still a good root. So, what are the strategies for missing canines? One strategy could be space closure by premolar mesialization. The second strategy could be to retain the deciduous canines until the end of growth and to preserve them, the alveolar bone, and to replace them later with implants. Or is there a third option? And we have to ask ourselves, and if there is no bone, and like in Sonia, on one side there was no bone. There was an osseous defect in the area of the canine, of the deciduous canine. What are we going to do? We have to think outside of the box. So this is the upper arch. What are we going to do? We are going to extract both deciduous canines. What are we going to do? We are going to mesialize the upper first bicuspids, both of them, to replace the missing canines, and we are going to open a space between the first bicuspid and the second bicuspid. And this is the end of treatment, where we see that we have nice hard and soft tissue in the region which we have created between the first and the second bicuspid. Panoramic X-ray before and towards the end of our treatment. We are looking for root parallelism, we are looking for root resorptions, and the sequence, once again, a sequence of our treatment. Once again, end of finishing, where we open the spaces which have been replaced by implants and provisional crowns. And this is the occlusion after our treatment and the restorative work of our team member, Dr. Pelliteri. And this is her profile and her smile. And this is the Ceph before and after treatment. And this is the panoramic X-ray before and after treatment. We have replaced the missing canines, but on the side of the first bicuspids with implants. 2 years later, occlusion, 2 years later. And what I would like to show you, that we pay a lot of attention of good final occlusion. We want to achieve a good stability, we want to achieve a good function, and why not improve aesthetics? We do a lot of composite restorations. You see the worn incisors due to the accentuated curve of speed, which we have been reconstructed. We have reconstructed the back-shaped laterals. We have reconstructed the hypoplastic central incisors, and the canines are the new bicuspids. So before and after our treatment, once again, I dare to bet with experienced eyes to find out which tooth is which tooth, if I'm going to show this picture. Coming to the second point, development of tooth malformations. I don't have time to go all over these points. I would like to share with you the delaceration. Delaceration is caused by traumatic non-axial displacement, very likely, or by idiopathic development disturbances. how can we face delaceration? We can apply an early orthodontic traction, maybe promote better root and labial bone morphology, and a joint orthosurgical endoprosthodontic approach is of utmost importance. There are two possibilities. Once again, we have to think outside the box. And I would like to share with you Karen. Karen came to us at the age of 8 years in 99, more than 20 years ago, with a retrognatic mandible, with crowding in the upper arch, with missing teeth. And this is her intraoral situation. A full class 2 on both sides, crowding in the upper arch, anterior crowding, the lateral incisor is in crossbite, and the Ceph reveals, shows us a class 2 malocclusion, and the panoramic X-ray shows us a delacerated 21 with severe crowding in the upper arch. What is our treatment plan going to be? We are going to extract immediately the impacted, delacerated tooth 21, and we do serial extractions on 53, 62, and 63. What are we doing afterwards? Nothing. Monitoring. 4 years of monitoring, just observing and doing nothing, letting Mother Nature do her job. She's doing very well. And then we are going to extract tooth number 14 as soon as he has erupted. This is after the first phase of serial extractions. We are waiting until the eruption of tooth number 14. We see that there is an incomplete transposition of 23 and 22. We are going to extract 14. We wait until all permanent teeth have been erupted, and then once again 4 years of monitoring, and then we start our treatment with very simple mechanics. This is during our space closure with our braces, nothing special. We're trying to bond the brackets on the right spot. We do some gingivectomies, we do some composite reconstructions, and sometimes if the brackets are not doing their job properly, we have to take our plier and to make some old-fashioned wire bands in order to obtain the correct torque if we are not able to get it with our appliances. Afterwards, we do some provisional composite restorations, and this is the treatment result after 22 months of treatment. We finished with the class 2 molar relationship. We did some composite restorations on 22 and 23. This is the final result, smile. And this is the Ceph before our treatment and after our treatment, and the panoramic X-ray before and after our treatment. You deserve to see our final panoramic X-ray in order to see how we ended, how much root resorptions we have obtained, how good our root parallelism was at the end of treatment. And now we're waiting until the eruption of the third molars in order to utilize them or in order to extract them. And this is the patient 6 years in retention. She received ceramic restorations in ceramic crowns on 22 and 23, some composite reconstructions on 11 and 24. She still has a nice solid occlusion. And now the third lower molars have been removed and the upper third molars have been erupted, and now she has 28 old teeth this should be our treatment goal. Once again, before we started and after treatment. And now we are able to show her 14 years in retention. It was last year where we started, 14 years ago, many years ago. And occlusion before we started and occlusion 14 years in retention. And this is her smile, now 14 years in retention. Who dares to say that we have extracted one central incisor? I guess nobody. 14 years in retention. Solid occlusion. I hope you agree. So, coming to the third point, to the avulsion. Avulsion are 8% of all dental traumas, mostly between the age of 7 and 14 years. Most of the 45% it happens at home, 45% at school, 10% at sports. More males than females, and most of the time they have an increased overjet, more than 6 millimeters, and most of the time 64% of all avulsed teeth are maxillary central incisors. It happens, the avulsion happens normally always on a weekend, during the holidays, never during the week. And the parents are very desperate when such an accident happened, so they are happy if they find somebody, a dentist, who is going to replant these avulsed teeth, but they don't know, the parents and the dentist don't know what happens to these teeth, because they very likely lead to root resorptions, ankylosis, and infraocclusion. This is the destiny of avulsed and replanted incisors or teeth. And this is a good example. Johanna, she came to us at the age of 12 years. You see ankylosed and infraocclusion of upper central incisors. They are too short during the smile. And if we look in the mouth, we see a deep bite, we see an infraocclusion of the upper central incisors compared to the lateral incisors. We see a very accentuated lower curval speed. We see some tendency of gingival recession on 31. This is a profile, a slide class 2 profile. Once again, the infraocclusion of the central incisors can be noticed. And this is her intraoral situation. A more or less class 1 occlusion with splaying out protruded upper incisors, deep bite, infraocclusion of the upper central incisors compared to the lateral incisors, severe crowding in the lower arch, anterior part of the lower arch, a mixed dentition with several deciduous teeth still present. We see that the upper left lateral incisors has been devitalized and has been treated endodontically. She is exhibiting a slight class 2 malocclusion. So, if we look closer to the panoramic X-ray, we see root resorptions ongoing on the central incisors. What are we going to do? We are going to do nothing. Okay, waiting until eruption of more permanent teeth. And we wait for 1 year, 12 months, and we realized that the infraocclusion got worse during these 12 months, as you can see here. Got worse the infraocclusion due to the ankylosis of these central incisors. And you can see that even the accentuated curval speed in the lower arch has increased due to the effect of this infraocclusion. Now we take a new panoramic X-ray, and now we are going to propose the treatment plan, our treatment plan. Our treatment plan consists in extraction of these ankylosed infraoccluded central incisors you see the ongoing root resorptions, and our treatment plan consists of extraction of the lower first bicuspid. And these are the extracted teeth. You see the root resorptions, there's not much been left. And this is Johanna after the extraction of the two central incisors, always in a good mood. This is the day when we started our treatment, the day after the extraction has been performed. And with a very straightforward treatment mechanic, we are closing the spaces, very comprehensive treatment approach, nothing special, absolutely nothing special. We are closing spaces in the lower arch. We try to bond the brackets on the right spot from the beginning in order to avoid laborious rebracketing, but sometimes it's necessary, and you will see that we did it here too. We are coming towards the end of our treatment. The spaces are nearly closed. Again, we take a smile picture in order to check the smile, in order the smile aesthetics, the smile arc, the smile line, if they are consonant, harmonious, and we do some, in her case, some gingivectomy. We take an X-ray, panoramic X-ray, in order to check root parallelism, in order to check ongoing root resorptions, very important towards the end of treatment. We do some rebonding, we take the brackets off, we do some reconstruction with composite in order to get a better orientation towards the end of treatment. As you can see here, some very simple reconstructions with composite material, and we do rebonding of the four incisors, the two lateral incisors, the two canines in this case, where we aim to intrude even more the lateral incisors, which are going to be the new central incisors. We are going to extrude the canines in order to obtain a better smile aesthetic, better aesthetic of the gums. And this is the treatment result. Nice class 1 occlusion on both sides. We did some reconstruction with composite, we did some gingivectomy, and we obtained nice arch forms, no space. Panoramic X-ray before treatment, panoramic X-ray after treatment. We are looking for root parallelism, we are looking for resorption, and we are monitoring the eruption of the third molars in order to end up with 28 teeth. This is the final treatment. Her lipping competency has improved. She still has a sort of gummy smile. And this is her final occlusion after the restoration of her general dentist. Nice occlusion. Don't argue with me about the quality of the prosthodontic rehabilitation. Unfortunately, not every patient can be sent to the best restorative dentists in Italy, and we have sometimes to accept the outcome of the family dentist. Fortunately, you see that the third molars are erupting, so our aim is to end up with 28 teeth. A free gingival graft has been replaced here after our treatment. You see there was a gingival recession at the beginning, so we had to perform a gingival graft. We do it at the end of treatment in her case because we want to align, to close the spaces, and then we are going to judge if there is a necessity here to perform a gingival graft. Before and after treatment, leveling of the curve of P is very important for us, that it's very flat in order to prevent a deepening of the bite in the retention period. And this is the situation after her restoration. The smile has improved. And once again, the smile when we when we saw her the first time and at the end of the prosthodontic rehabilitation. Smile aesthetics, and once again the smile. Arch form before, arch form after our treatment, after the extraction of the central ankylosed incisors. And some years later, very stable occlusion, nothing happened. And this is our final treatment result. I think that this was the right treatment option for Johanna. At least for our daughter, we would have chosen this treatment strategy. Now comes Barbara. Barbara comes to us at the age of 8 years in 2004 with some sort of class 2, skeletal class 2, some sort of dolichofacial growth pattern, crowding in the upper arch, lip incompetency. And this is her occlusion. It's a mixed dentition, as you can see here. It's more or less a class 1 with crowding in the upper arch, crossbite of the lateral incisor of one lateral incisors, melogenesis of some incisors. And this is her Ceph, which reveals skeletal class 2, which reveals a hyperdivergent growth pattern. Panoramic X-ray reveals crowding in the upper arch and the lower arch. What was our treatment proposal? Our treatment plan was serial extractions. Okay, serial extraction of all 4 deciduous canines. And she came back 1 year later after the parents have extracted just the upper deciduous canines, not the lower, as you can see here, because patients don't like to extract teeth. So they did 2. And you see what Mother Nature did. It spontaneously, the lateral incisor and crossbite corrected spontaneously without doing anything. Our treatment plan consisted in serial extraction of the Cs and then later on in extraction of the first bicuspid. But what happened? Barbara came back 5 years later. She disappeared. She disappeared because they didn't want to hear 4 bicuspid extractions, as it happens every day. People don't like to hear about extractions. She came back forced. Why forced? Because you will see, she has crowding in the upper and the lower arch. You see some inflammation here. And you see what happened. She had a sled accident at the age of 12 years where she broke her mandible, where she broke her condyle, where she has got a avulsion of 3 incisors. And then she came 2 years later, 2 years after this accident, at the age of 14 years. Crowding, class 2, lip incompetency. And this is now her intraoral situation. More or less a class 1, crowding, protrusion of the upper incisors. Here you see a bonded retainer. And this is the Ceph, class 2, dolichofacial bimaxillary protrusion. And if we have a look at the panoramic X-ray, we see root resorptions on this tooth, on this tooth, on this tooth, and you see there's a sign of a broken condyle on the left side. You see apical inflammation on this tooth, on this tooth. And if we have a look at the periapicals, we see ongoing root resorptions, ongoing root resorption, ongoing root resorption, 31, 32. So our treatment plan now has changed from 4 first bicuspid extractions due to the fact that we have severe root resorption ongoing on incisors. So we have to think outside of the box. I'm sure and I'm convinced that you agree that these 3D cannot be maintained. No roots, no roots, no roots, ongoing root absorptions. But this is an odd number. 3 is an odd number, and we are looking for symmetry. We are looking for symmetry, so we have to decide to extract one more tooth in the upper arch. Which one are we going to extract? You can decide. We decided to extract this tooth. And if you propose such a treatment plan to the parents, they are going to ask some colleagues around northern Italy. They went for second opinions to 5 other colleagues. And I understand them. We understand them, because it's a very, very great, difficult decision to swallow, to extract these incisors. I can understand them. We can understand them. But what are the alternatives? Finally, after a long discussion, after 6 months, they came back and they accepted our treatment plan. They went to extract the 2 central incisors, upper central incisors, and 31. And I told Barbara, go to the dentist in the evening. He's going to extract these 3 incisors for the moment, and then we are going to talk about this incisor. And I promise you, you are sleeping only one night without 3 teeth. The next day, you will get out of the office early in the morning. We give you some teeth in order that you can go to school. And so we did. This is then where we started the treatment, closing the spaces in the upper and in the lower arch. We did a root canal filling here on this tooth, and I'm going to tell you why. Then after 9 months, we closed the space of the extracted 31. And now I told her, now you can go ahead and extract 32 as well. Why didn't we extract immediately 31 and 32? Because we have never seen in a case report that somebody dared to extract 2 units on one side and no unit on the other side. Okay, very, very strange, very odd situation. Very weird. So, as you can see, this is during treatment. Now we ask her to extract 31, and we started closing the space of 31. No sophisticated mechanics at all. Sliding mechanics to close the spaces, sliding mechanics to center the midlines, which are, because our new midlines are between 41 and 42. We are going to close the spaces. She's very compliant, wearing 1 class 2 elastics on one side, which helps us to close the spaces, which helps us to correct the midline. And now we are coming towards the end of treatment. You see how we placed the brackets. The brackets on the lateral incisors have been placed to intrude them and to extrude the canines in order to end up with a nice smile line. So we started with the extraction of these 4 teeth, and this is our treatment result. We overcorrected the midline because this is 41 and this is 42. These teeth have been reconstructed with composite material, nothing special. This is the occlusion on both sides. Class 1 occlusion on both sides, midlines are coinciding, nice arch forms, no spaces. Before and after, before and after. Profile before and after. Smile after our treatment. Cephalogram before treatment, after treatment. Panoramic X-ray before and after treatment. Nice space closure, overcorrected. You see the broken condyle is still here, is still present, and we're waiting for eruption of the third molars because we're going to include them in our occlusion, in our treatment plan. We won't end up with 2018. And 6 years later, in retention. After 6 years, we asked her to go to our friend, the dentist, for ceramic veneers because we asked her to make a case report to publish her in the AJO. And her answer was, no, I'm so fine, I don't want any improvement. I like my teeth. So this was the situation after some years. Once again, 41, 42. And this is the reconstruction of the upper, after lateral incisors and the canines with composite. This case has been voted as the most interesting case in our society in annual meeting in 2014, annual meeting of the Annual Society of Europe. And it has been accepted in the AJO and it has been published in January of this year as a case report. This is the case report of Barbara. So, coming to my last patient, which I would like to share with you, Eva Maria. Eva Maria came to us at the age of 10 years with this smile. With this enormous defect here, osseous defect, soft tissue defect. This is her profile, very flat profile, bimaxillary retrusive, some class 2, facial asymmetry, scar. And this is her intraoral situation. A class 1 on one side and a class 2 on the other side. Class 2 subdivision, challenging. Plus this defect, enormous defect here in the late mixed dentition. This accident happened at the age of 15 months. And these are pictures of her infancy. During the infancy, she all had this enormous defect here. She never was complaining. And then when she came to us, we took her Ceph. This is the Ceph, where we see a hyperdivergent class 2 subdivision, asymmetrical. We see a maxillary trauma at the age of 15 months. We see this defect, hard, soft, and soft tissue defect. We see the loss of the central incisor, a delacerated lateral ankylosed lateral incisor, and we see transposition of the canine, of the upper left canine. So, once again, we have to think outside the box. It's not the regular one of the group. In what consists our treatment plan? Our treatment plan consists of a homologous bone graft. This was the first step. Then we forced the eruption of the impacted bicuspid. Our treatment plan was to mesalize 24 on the place of the 21. Then we waited until the eruption of the left canine, and then we had to extract 3 more bicuspids. Then was planned a space opening for upper left lateral incisor, and finally we had to replace 1 missing teeth in the upper left quadrant with an implant, and we had to perform a crown on the 24. This was our treatment plan. After the homologous maxillary bone graft and extraction of the least delacerated ankylosed lateral incisor, the maxillary surgeon was not able to remove this ankylosed root of this lateral incisor, and second surgery was exposure of the impacted bicuspid end of the canine. You still see that as part of the root of this delacerated impacted lateral incisor. How did we bring this impacted tooth into the arch? Very simple, with a old-style Nance appliance, and where we are pulling the bicuspids down into the arch. Then we are waiting. The bicuspids are erupting, and after 1.5 years, both bicuspids have been erupted. now it's ready for second phase of treatment. After extractions of 3 bicuspids, now we are moving the first upper left lateral to the center in order to replace the central incisor. Canine is erupting, it has a melogenesis, and we are closing space in the lower arch. We had to extract due to crowding, we had to extract due to accentuated curve of speed in the lower arch, and we had to extract due to proclination, protrusion of the lower incisors. Once again, in the face of space closures with some uprighting springs, nothing special, very straightforward mechanics. And now we are coming towards the end of our treatment. You see that we are pushing the first bicuspid even more to replace the central incisor. Class 1 on both sides has been achieved, no deep bite anymore. And Ceph, before we started, and Ceph at the end of our treatment, you see that the torque values are very, very the same, nothing has changed, the same torque values, even though we have extracted 4 bicuspids. Panoramic before our treatment, panoramic after our treatment. You see there was no bone, now there is enough bone, waiting until the eruption of the third molars. And this is the final treatment result. We reconstructed this bicuspid in order to improve the aesthetic. And then at this point she decided to go 1 year abroad in school, and she went to her dentist, family dentist, and I talked to him and I asked him kindly to replace this tooth with a kind of Maryland bridge, adhesive bridge, in order not to touch this tooth here. What did he do? He performed a regular bridge. He preparated this tooth here and he prepared the bridge. He damaged the soft tissue here, and then she went for 1 year abroad. This is the situation when we finished, when she came back from abroad. Yeah, well, yes, we started here, we finished here after this ugly and provisional bridge. Then, fortunately, we could convince her to go to one of our team members, Dr. Pelletieri, where he did an excellent job. He performed hard and soft tissue grafting, and he placed an implant. You see very nicely. And this is the situation of the soft tissue after his beautiful mucogingival surgery. The mucogingival surgery has been performed by one of the wizards in the world, by Dr. Zucchelli. Dr. Pelletieri placed the implant and did the prosthodontic rehabilitation very nicely. And this is now the final treatment result after a long story. Occlusion, nice midline coincidence, and the soft tissue is still maturating, it's not yet finished. And here, we started here, we arrived here, and we started here, and we arrived here. Of course, I have to show you the panoramic X-ray before we started, and at the end of our treatment, we had to replace, unfortunately, one tooth has been replaced, periapicals, and this is during the 11 years of observation and treatment. We started in 2007, and finally we ended in 2018. Long time,